Good evening, everybody. Sorry, we were having a couple difficulties with some technical things there, getting everybody online and ready to go. We're going to give it just one more minute, and then we're going to get started. As I see some more are trickling in, into those just trickling in. Thank you for being patient with us. Just a couple difficulties getting going earlier. 1 second, and we will get going. All right, I think we're starting to top off a little bit. Let me see. Okay. Good evening, everyone. Thank you for joining our Men's Health webinar. My name is Preston Brickner. I'll be your host and moderator tonight. First, going to start with just a few housekeeping items, then I'm going to turn it over to our speaker. First off, your attendance is completely anonymous to all the other attendees. No one can see your face nor your name. Any comments or questions will only be seen by myself and our speaker. If you wish to ask a question, type it in the chat box. That should be at the lower part of your screen, and we'll be sure to answer it at the end of the talk. Talk with the Q&A should last approximately 1 hour and will be presented by Dr. Christopher Schaefer. Dr. Schaefer is a urologist with New Jersey Urology. He received his medical degree in osteopathic medicine from the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine. Went on to complete his residency at the Philadelphia College of Osteopathic Medicine. Dr. Schaefer, I know you're a really busy guy. Thank you for your time. Why don't I go ahead and just turn it over to you?
All right, great. So I have control of your slides via the bottom here, so I'm going to use that, I guess, to go back and forth. Well, welcome everybody. Hopefully you can hear me okay. I know these computers aren't always 1,000% nowadays, but so I've done these talks quite a bit, and it's always a little bit odd on the webinars because I don't see anybody's faces, but welcome. So I'm just going to quick introduction to myself. I'm located in Langhorne, Pennsylvania by the Oxford Valley Mall area, if you guys know the area at all. And we've been there for quite some time. I've been with the practice since 2007. So it's been almost 20 years of working with the community and the patients in the community. And some of you I know have told me you're my patient already and on these calls as well. So welcome again. I probably saw you today or yesterday, but we'll see. So I'm going to talk a little bit about erectile dysfunction and incontinence. I don't just do those things, but that's one of the things I focus on. And we'll get more in the weeds on that in a minute. It's going to be relatively informal. I don't have a agenda or deadline. I just want to go through the slides one at a time. And like I said, we'll talk about things at the end if you have questions between the two topics. So I'm going to move on to the actual slide presentation at this point. There is some disclaimer slides, which I'll leave on for a hot second, but just Boston Scientific is nice enough to put together this slide deck for me. So as far as if you have the first topic is going to be erectile dysfunction. So this is if you want to write down this website, it's edcure.com. It goes into a little more depth about some of the options available about erectile dysfunction, treatments, causes, whatever. But I'll go into that as well. And there is a QR code here if you want to scan it. But I'm going to move on to the next slide. So, all right. So let's learn about erectile dysfunction. It's kind of a broad topic, but we'll narrow it down to some specifics. So as far as erectile dysfunction, it's sort of not a strict definition of saying, I can't get any erection. It may be an erection that's not suitable for adequate sexual intercourse or to your satisfaction. And it's very common. I mean, this is something that a lot of guys are talking more and more about than they used to in the past. But if you look at this slide here, it says 1 in 5 men age 20 and older. That's 20-something-year-olds. So once you get to 40, that number is almost half. It's more than half, in fact. So that's something that, is a pretty common problem out there that more and more solutions available for and more people willing to talk about as well. So it's not something that as you get older, you just accept it and move on, but there's ways to fix it and look into it, which we'll get into here. So this is the general erection process. Basically starts with arousal. So you don't just sit around and get erections for no reason. There's some stimulation there. So the nerves that send the signal to the penis to open up the blood flow into the penis, which then fills with blood and gets rigid and stiff. And that's the erection part. And as it sort of expands, the veins on the outside that normally drain the blood away are sort of compressed. And that keeps the blood there. And we'll talk about why that's important later as far as that venous drainage. But for the most part, blood flows in and stays in. That's what keeps you erect and hard. So as far as the causes of ED, this pie chart to the side sort of goes into it a little bit, but you see the big chunk of it is vascular at 40%, where vascular meaning blood flow. There's some damage to the artery, vein, or a combination of two, and even the arteries and veins that feed and drain the nerves as well. So that's a big chunk of the causes. Diabetes is another big chunk as well. Diabetes sort of accelerates vascular changes that occur with time. So normally someone who's not diabetic may start developing symptoms and issues in their 60s, but we see diabetics as young as in their 20s and 30s develop these problems because of vascular damage. So some of the risk factors, that go into this as well is some medications that sometimes cause it. Some of those are blood pressure medications. Other ones are ones for psychiatric medications. And then the smaller slices of pie are more less common things like surgery, neurologic issues, and whatnot. Risk factors that can affect vascular besides diabetes is things like smoking, age-related changes, high blood pressure, high cholesterol. And then there's some psychiatric or psychological changes like depression, where your interest in sex gets a little lower, and then therefore the erections aren't as good. So next slide we'll talk about is, why is it important to fix this? Well, obviously for the recreational purposes of things, but there's self-esteem issues and some psychological issues that can occur by not getting good erections. Some guys feel less of a man. Some guys don't feel like they're able to satisfy their partner. And that can lead to breakdown in communication and relationship issues as well. So it's not just for fun, but it's also for intimacy as well. So guys that have these problems tend to be a little reserved about talking about it, but that's why I tend to prod the question when I see patients in the office and say, "Hey, what's going on with this?" And they'll oftentimes without volunteering on their own, will say, "Oh yeah, I do have some problems, but." And I say, "Well, there's ways to fix that," and we'll talk about those in a minute. So I'll briefly touch on diabetes and why I mentioned earlier about diabetes being a big chunk of the cause for ED. And if you see, more than half men have problems with erectile dysfunction or sexual problems from the diabetes itself and the damage to the arteries and the nerves that feed the penis. So this is an example of that. So you see this graph to the side, this diagram shows you this yellow part is the nerve. And around the nerve, there's these little blood vessels that sort of feed that nerve. And over time, those vessels they're very small and they can be clogged by damages from the long-standing sugar control issues. And when you lose blood supply to these nerves, the nerves start to fracture and not transmit the signal properly. And that leads to the loss of nerve function, thus the erection problems. So as the longer you have diabetes, the less sugar control you have, the more associated vascular disease you have as you get older, plays a role and it compounds to causing more erection problems than in the beginning. So, and then this is a slide that's just going to talk about heart disease. It's not that heart disease itself causes erectile dysfunction per se. It's that the blood vessels that feed the heart are sometimes the earlier size vessels, and I'll show you in a slide, can get clogged up. So I'm going to skip this one for now. So this is the example of why heart disease plays a role and why erectile dysfunction sometimes is an early sign of heart disease. So if you see here, there's different sizes to these vessels on the bottom. The smallest one, as you can see, is the penile artery. That's the artery that feeds the penis for blood flow for erections. The next one that's above that is the main artery that supplies the blood to the heart. So the penile artery being 1 or 2 millimeters in size, and the one that's next biggest up from that feeds the heart is 3 to 4 millimeters. So if someone has erectile dysfunction, especially at a younger age, it's suggesting that there's some clogging of that artery, that small artery. So if that clogs, the next one to clog would be the next largest size, which is the one around your heart. The larger vessels on the side here, this internal carotid and femoral artery, the internal carotid is the one that goes to your up your neck and to your brain. And when that gets clogged, it can cause stroke-like symptoms and whatnot. And then the femoral artery is the one that feeds the leg, and that leads to pain with the walking, and they call claudication. So basically, an early, the sort of the parakeet, so to speak, the canary in the cave, as they say, could be the penile artery showing an early sign of vascular damage. Thus, I often refer patients to their cardiologist to make sure they get a regular screening EKG and checkup to make sure that their heart's okay, rather than just assuming that it's age-related and your erections just get lost as you get older, which does happen. So, how do we prevent that from happening? Things you've been told forever, and we always change the goalposts on this, but, healthy living, watching what you eat, losing weight, stopping smoking is one of the biggest ones. Smoking causes significant damage to the arteries that feed everything in your body, including the penis. So when patients are smokers, I sort of highlight that as being a side effect of smoking that they oftentimes don't want to have. So it's rather than tell them, oh, lung cancer, which is sort of like mythical and maybe it won't happen to me kind of thing. But when you talk about losing erections, that hits a little closer to home. So healthy living, as they say. So I'm going to touch briefly on low testosterone and erectile dysfunction. It's not that the low T itself causes the erection problems directly, but it's sort of an indirect way. Because obviously we talked about needing some arousal, and if your testosterone is low, you may not get that arousal. So low T testosterone is made in majority of times in the testicle, the 85 to 90%, and a small amount in the adrenal glands that are sitting above the kidneys. And as we get older, those T levels can vary and fluctuate and typically decrease as you get older. So as part of my workup for someone who comes to me for the first time with erection problems is to look at testosterone and see if that's playing a role. If I could at very least get your interest in sex a little higher, that may increase your desires and thus the arousal part of the erectile issues. I can't fix the vascular problems with that, but that's a different way. We'll talk about those in a minute. So low testosterone is something I look into. And what does low T mean? Well, there's things that testosterone does in the background that help with just male health overall. So if you notice a decrease in your sex drive, depression issues, erection problems, difficulty in gaining lean muscle mass, sort of increasing body fat, that could just you be not working out enough and not eating properly, but it could also be low T. So we do check it as a baseline to see where it's at. And then the other thing that testosterone does in the background is it does build lean muscle and bone health for warding off osteoporosis and fractures in the future. So even if someone feels like they have no issues with sex drive and their erections are fine and whatnot, if their testosterone's on the lower side, I tend to want to at least offer options to raise it a little bit. So, and then those options I'm not going to get into on this lecture, but testosterone's the top two injections and gels are the most common ways of replacing testosterone. There's also oral medications. I tend to try to use meds that boost testosterone rather than replace it, at least to start with, and see if we can get the levels up. Reason being is that testosterone is sort of made by your body, and if you take it somewhere else, whether it's a shot or an injection or a patch or cream, your body will sometimes downregulate its own production. So I try to boost it first and see how that goes. But there is a role for testosterone replacement in some patients. Sort of a separate topic though. But the big one we see though is, and part of that pie graph we had showed some surgeries as a cause for erection issues. So prostate cancer treatments, specifically surgery, but also radiation, can cause damages to the nerves that give you erections. So nowadays we do nerve sparing surgery for prostate removals. So that's the robotic way where we have a better understanding of where nerves lie in relation to the prostate and leave those nerves behind. Years ago, when we took the prostates out via the open approach, they didn't really have a way of sparing the nerves as easily. It's hard to really zoom in on that area and see. With the robotic approach, they get really zoomed in on that area and they can see the nerve bundles on each right and left side, and they kind of drop them away from the prostate, leave them behind, remove the prostate and the cancer that's with the prostate, and the nerves remain. Now, that can cause a temporary erection issue because when you stretch a nerve away from some area, you could have what's called a praxis injury. That just means that the nerve has been stretched and may recover. So we don't do much for the first year or so. So if someone has erection problems after surgery, we kind of wait and see what happens for the first year. If they persist to have issues, then we obviously go to fix it. So this slide showing where the prostate lies in relation to everything. It's not really greatly shown in this picture, but the prostate sits between the bladder and the urethra. And right behind the prostate, closer to the rectal side, there's nerves that run underneath there that feed the penis to give you better erections. Those are very close to the prostate. And when you do surgery, you can intentionally or accidentally injure those nerves. Sometimes if there's cancer outside the gland or outside the capsule of the prostate, we don't want to leave those nerves behind because it is a cancer surgery. So if you're leaving cancer behind just to spare a nerve, that's not good for the patient for survival. So we sometimes have to take a nerve or both. We try to leave them both if we can. So it's pretty common. I quote around 50% can have this issue. These numbers are a little varied based on how you are going into it. But with robotic surgery, they can really zoom in on that area and do a much better job than we used to in the past. So it's not something that's, just because you have surgery, you're definitely going to be having erection problems afterwards. It's not really talked about in this. I'm going to go back a second. It's not really talked about in these slides because it's talking about surgery, but radiation itself can also cause nerve damage. As the prostate sits inside the pelvis, the radiation goes right into that pelvic area and kills the cancer, but it also can damage the nerves that are behind the prostate. Not typically something you see right away. So with surgery, you tend to get erection problems sort of immediately, and then you get better from them. Whereas with radiation, you're actually okay at first and get worse over time. So it's not something that's definitely going to happen, but is, can with either approach. So I'm going to dive into the treatment options, and it's going to be sort of broad, but I'll focus on each individual one individually. So there's a brief overview of options here. You got oral medications, vacuum pumps, injections, and then penile implant. And I'll just talk about each of those ones individually. So as far as the pills, you guys have heard of all these things. There's Viagra, Cialis, Levitra, a couple other ones that came and went, like Stendra and Staxin. They were out, just not marketed as well as the other ones, so they kind of fell off. These are all pretty much available generic nowadays and fairly affordable. So I want to just caution you guys, if you're looking for a fix for erections, you don't have to go to the internet. Just come to us as urologists. We can get you much cheaper, much more affordable medications, and it's the real deal, so to speak. I will say there's a lot of people come to me and ask me about what about this I saw on the internet? What about that on the internet? And a lot of those things you'll see on like Hims and whatever. Those are really just mixes of Viagra and Cialis together. They might tinker with the dosing a little bit. They might smidge it up from 10 to 15 milligrams or whatever. But at the end of the day, it's the same thing we've had since the 90s. It's the Viagra, Cialis, Levitra, those three. Pretty effective in the early stages, not so much for nerve damage or severe diabetics, because they really have significant nerve damage and or vascular damage. But these are ones you might have heard of. They're probably the starting point for most patients. By the time I'm seeing people, they're often have already tried these already and failed. Some of the side effects more common with these drugs can be facial flushing and headache. Levitra and is not as commonly used, but the Cialis and Viagra, we see some blue-green tint to the vision with the Viagra and low back discomfort with the Cialis. But we try them first and see. I usually try two of those, two or three of those at the most. But if you try one or two and they're not working, the third one's not likely to be as effective. So, but most people eventually have to move on to something a little more robust. So this is the vacuum pump. Not quite a big seller because it's a little bit awkward. You have to put a plastic sleeve over your penis. It relies on suction power. So when you turn the device on, they're either manually where you squeeze a pump or battery operated. And what it does is it draws blood in the penis through this vacuum mechanism. And then you slide a ring off the back of the tube to hold that blood in there. If you can kind of see closely to that slide that shows the erect penis, they intentionally put a little bit of different color there because it's sort of purplish looking, almost like darker. That's because that's what it's doing. It's literally compressing the veins so you can't get the blood out of there. That's where I talked about earlier with the venous leak where the veins get compressed. Sorry about that. My dog. Sorry, my very unprofessional dog got crazy there. The veins get compressed when you have a natural erection. Sometimes you have leak of that those veins where it starts to leak out early. And some guys will describe a very stiff erection, but then within a minute it starts to go down. Those rings that you see on that bottom are helpful for some of those patients outside of the vacuum device that helps hold those veins from leaking blood out. So that's not really, it's kind of cumbersome. You got to break the mood, go put the thing on, pump it. I don't really see a lot of guys using this. It's out there, but not really a big seller. This one's the injections. So if someone fails oral medications, I really offer them two options after that. One is the injections into the penis, and the other one's an implant, which we'll get to. So these injections are basically the same concept as the oral medications. It's trying to increase vascular flow to the penis to get better stiffness, so to speak. These bypass the need for absorption like the pills do. The pills you have to take and they got to wait, and then it gets absorbed by your body and goes down to the penis to work. This one bypasses all that and goes right to the source. The downside is yes, you have to put a needle into your penis. Does it hurt? Uh, it's more like a pinch, if anything. It's a very, very small needle. It's an easier sell for existing diabetics that are already on insulin because it's literally the same syringe. It's a 31 gauge, if you know what that means. Very small, short syringe or needle that goes in the penis. If patients want to go this route, you can't get this at a CVS or a Walmart, Walgreens. It's got to be ordered through a compound pharmacy. And then they come in the office and I show you how to do the first shot. The benefit of this is that you can increase the dose to what works for you. The Viagra's and Cialis and oral medications have a ceiling. You can only go so much. They have a max dose, so to speak. This one you can keep increasing to get the desired effect you want. Eventually, though, if you keep using more and more of this stuff, the volume wise, it's not working. You probably need to move on to the next step. And that's usually an implant. So the implants, there's a couple models out there, but I'll talk about the inflatable one primarily. So this is an implanted device that I put in the OR while you're asleep. It's all concealed. So none of this is outside your body. You don't see it. You'll feel it through the skin, but you won't see any of these components at all. So the way it works is there's a cylinder that's in the penis. Let me see if the next slide's got a better picture of it. Well, there's the three options here. This two pumps, they're just slightly different. The yellowish looking ones are the inflatable models. The one to the far side is the original one, and there's a newer pump called a Tenaccio pump. It's a slightly different feel to it, probably easier to grip. The one to the far, the whitish one, is a malleable prosthetic. That's not really commonly used, but it's available mostly for patients that don't have the ability to squeeze or can't use their hands. So the inflatable pumps you pump up and you get them hard by pumping, and I'll show you a video in a second about that. But the malleable one is basically a bendable rod. So it's these two rods are inside the penis, and when you want to have sex, you bend it up to get it stiff, and then bend it down when you want it out of the way. So it's not really a great seller for people that have use of their hands because you want to be able to hide that erection. This one, the malleable, you can't really do that. So this is the inflatable model. So there's three components to it. There's a reservoir that's behind the bone to the far side of the screen that is that holds fluid in it. And then there's two cylinders that go inside the penis that give you the erection that fill up with saline. And in the scrotum is a pump, and that pump is activated by you. So when you want to have sex, you pump it and it makes those cylinders fill up with water or saline. It get hard. And when you want it to go down, there's a small little button that you use to deflate it. The nice about these things is that they're sort of natural looking when they're not in the erect phase. So if you walk around, you wouldn't notice someone has one unless you actually touch the area. So it's pretty easy to hide the device inside when you're in the flaccid or non-erect state. So this is a video. Can you slide up a little bit, Preston? I can't see.
Next. Just hit next and it'll go.
Oh, it will go next. All right, gotcha. So this is a device, little animation, how it works, and I'll let the video speak for itself. I guess this is showing that you don't see it. This is what's inside your body that you don't see but feel. So you pump the pump up and the penis gets erect like you're seeing here. And it's drawing fluid from that reservoir that's up by the bladder, up the high part. That's where the fluid is held. And when you want to go down, you push the button and then the penis deflates and the water goes back into the reservoir. So you're sort of shifting fluid back and forth essentially. So that's that. All right. And is that all of it? And I think so. All right. So numbers as far as satisfaction. I mean, these guys are very happy once they get one because they're sort of foolproof. Once you put it in, it works because you're pumping it up and it's filling up with saline rather than relying on blood flow. The benefit of this one is that you can leave it up even after you have the sensation of orgasm. So when you pump it up and have sex and you climax and you want to keep going, you can because it doesn't deflate automatically like a normal erection would. People ask me also, can I ejaculate with this pumping? You can if you could before. The problem is if you've had your prostate removed, you will never ejaculate. That's not ever going to happen because the ejaculate comes from the prostate area. But if you have diabetes and you were able to ejaculate, yes, this gives you an erection. It doesn't do anything to the ejaculation or climaxing. It just gives the ability for you to have intercourse by making the penis stiff. But the most important survey that we have here is basically would you recommend this? And you see these are 95, 97% satisfaction and recommendation rate for this device. So it's really well received. So the procedure itself done in the OR, and yes, you are asleep for it. The device itself, there's some prep ahead of time, which I talk to patients about, but not much. Just some special washes we use and some antibiotics. And then when you go to the OR, you go to sleep and wake up with this device in you. You can't use it right away though. You have to let it heal. So typically it's about I usually wait 6 weeks to show them how to use it. Most guys are a little sore anyway, so they don't want to, really touch down there first few days. So you got to take it easy for a little bit. There is one incision. It's about maybe an inch or so in length that goes at the base of the penis. So basically where the penis meets the scrotum is where I make that incision. Other doctors do it in different areas, but that's where I do mine. And it kind of hides the scar a little bit. I like that option. So once you get the device, you wake up, you go home, you see me 2 weeks later for a post-op wound check to make sure you're healing okay. And then 4 weeks after that, which is 6 weeks from surgery, then I show you how to use it. So I show you how to pump it up in the office, and then you go home and you have the ability to do what you want as far as pumping and deflating. There is a bit of a learning curve. So I do want those guys to realize that if you do proceed with this, there is, you got to figure out where to put your hands and how you pump it up and how you squeeze. I know how I do it and it works for me, but I'm not you. So some guys use their non-dominant hand. I typically put the pump on the dominant side. So if you're right-handed, I put it on the right side of the scrotum versus left side. I also decide where I'm going to place it based on prior surgeries too. So if you had a right hernia surgery, I'm not going to try to mess around with that side. I'll go to the other side. It's not a big deal to reach across your body, but you do have to be able to reach down there and touch at least so you can feel where things are. So you got to expect 6 weeks waiting period. I had a funny story. A guy was trying to get one done for his anniversary, and he sort of scheduled surgery like the week before his anniversary. And I was like, oh, I thought I could use it right away. I said, no, I did explain 6 weeks. So if you got any plans like that coming up, like travel plans, make sure you've got well enough lead time to get used to this. Let's see. So as far as coverage, it's typically covered by most insurances. We do check that ahead of time. I do have some patients that are denied, and that's rare, but it happens. And I can't really go to bat for that as part of your insurance plan. We do try to do appeals and whatnot, but typically if you sign a letter on your insurance plan that says I'm excluding these procedures, then it's not covered. But typically it's covered, and surprisingly so. It was amazing for years they wouldn't cover Viagra, but they'll cover this, which is kind of ironic. But so let's see. The next slide is the risks of the procedure. So excuse me. The biggest risk for the procedure is, really infection is the biggest one we have. Bruising and swelling is expected with surgery, and that could be minor amounts or more major, but that typically heals with time. It's the infection risk that's the biggest one. Reason being is that if this gets infected, you have to take it out and put a new one back in. So we try to really do our best to minimize that risk. I do a lot on my end to prevent that from happening. I do some things on your end that you can do to help out with that. Really the ones that are biggest risk are the diabetics because they're at risk for infections in general. These devices, people ask a lot about how long these last. Well, the shelf life is about 10 to 15 years. It's on average about 12 years. There are mechanical parts and valves in there that can get sort of stuck and broken over time. So then if that happens, you can take the old one out and put a new one back in. But they're typically, I've got guys that have had these things for 20 years and they're still working. So it's not like it's going to break. It may over time. But again, the biggest risk that we have with this is the infection risk, which I do my best to try to minimize. So outside of that, that's this is the wrap up slide. But basically saying you're not alone in this problem. It's very common. It's very treatable and curable and manageable depending on how far you want to go with things. But it is something that is out there and we have ways to fix it. So I'm gonna, I think, end this part of it at this point. I think, yeah, because he learns about the next area. So if you guys have any, Preston, you want to stop here for questions about the ED side of things, and then
We could keep going just for the legal compliance things, just to keep it, we'll keep the
gotcha.
questions. But if you guys do have a question, just to reinforce, we will get to every single one of them that we can at the end.
Okay.
But if you have something that comes up as we go along, the bottom of your screen, there's a little cartoon bubble, probably says chat. Click there, type your question. Only Dr. Schaefer and myself will be able to see it, and we'll get to it at the end.
Okay. Sorry. So I'll move on to the next slide deck, which is talking about incontinence. This says male stress incontinence, but there's also some, other types of incontinence that are not necessarily addressed in here. And this is going to be primarily be focusing on, for the most part, leakage after surgery or radiation from prostate cancer treatment. So it's not going to be the average, guy that dribbles on the way to the bathroom kind of talk, but we'll talk about in brief as well on that. So as far as incontinence, there's another website you guys can go to. There's a QR code if you want to take a screenshot of that, or the fixincontinence.com is a website that you can go to that talks more in depth about these things. And there's some testimonials and videos and whatever. You can go there and check it out. But I'll start the slide deck about talking about stress incontinence. So this is what stress incontinence specifically is referring not stress like emotional stress. It's stress as in if you're picking up things or coughing or sneezing or laughing, you tend to have leakage. And this is focusing on the male side of things. This is very common in women as well for other reasons, but I'm not going to get into the weeds on that. But so this is we typically see this more in guys that have had prostate surgery, and the process by which urine is held inside the bladder is by a couple of mechanisms. One of which is the bladder neck, which is, does my cursor show up on here, Preston, or is it not showing up?
No, but I can kind of go for you.
All right,
Okay.
yeah. So if you can follow the cursor to the bladder neck and show them. So right above the prostate, where the prostate meets the bladder, we call it the bladder neck. And that is an area that is one part of the mechanism that holds the urine in. The next one just below that's the prostate, which is the pink organ there that you see that goes around the urethra. And the third one is basically the sphincter, which is just past the prostate where he's showing you there with the cursor. So the way it works is that your bladder has this sensation that has to go. The sphincter opens, the muscle contracts, and then urine goes out the urethra to the toilet. So that's the way urination works. And where things go awry is typically with things that can affect those three mechanisms. As you see here, the most common cause of that in men is removing the prostate. And if you remember the slide earlier, we do remove the prostate by cutting between the bladder and the prostate and the urethra and the prostate and then hooking it back together. So surgery is the most common way this can happen. Radiation can also cause this because that cause damage to the sphincter as well. Mostly because the sphincter can't be removed from the prostate when you're doing radiation. You can't, it's hard to like keep it away from it because it's so close to the prostate. And surgery, the same thing. So we have ways to sort of try to avoid that area, but sometimes in your best options, you can't really remove it altogether. There's some other causes besides radical prostatectomy or radiation. Certain neurologic things like Parkinson's we see. Prior prostate surgeries for benign disease like having TURPs or microwave or whatever to the prostate. And then urethral surgery for other traumas and things like that can cause it. So as far as prostate cancer treatment, let me just dive into that real quick. So here's what I was referring to is that you're cutting the prostate out and then you're removing two things. One is the bladder neck has been reconstructed to now accommodate the urethra to hook it back together. The other thing is that the prostate's removed. So that's two of your three continent mechanisms, leaving really only the sphincter that holds the majority of the urine back. And that sphincter is pretty tough in men, but sometimes if enough pressure occurs, you can have an overflow of urine out past the sphincter into the tip of the penis and dribbling. So we have a couple options available. One of the less invasive ways is managing it by behavioral changes. Those could be some guys will do what's called time voids, where they'll go on a schedule. So instead of waiting for your bladder to get really full, it just gets to every 2 hours, just go pee, so you're not totally full. And then obviously some guys will just drink less. So if you drink less, you don't pee as often, there's less leakage. There are some things like pelvic floor exercises, like Kegels and pelvic floor therapy that can be done to help restore the muscles. And then there's other ways you could just manage it by either trying to catch the urine, like with pads, diapers, external catheters like condom catheters, or even an internal catheter, or things like penile clamps, like Cunningham or Pacey cuff. There's a couple of ways to kind of squeeze off the urethra outside the penis to hold things in. Not the most comfortable way to walk around because either you're wet or you're having a bulky clamp around the penis to hold things in, but some guys do it that way. So there are other ways that we could kind of hold the urine in. This one's the male sling, which is it's a sort of like a hammock, and I'll show you the next slide what that looks like. It's basically like if you ever heard of women that get mesh for leakage, they have this thing called a sling. Similar concept. It acts like a hammock to hold the urethra up. And what it does is it creates a backing so the urethra does not kind of go downward when you cough. Nowadays, with the robotic surgery, they're doing some anchoring techniques to hold the urethra in place so it doesn't leak or doesn't drop down and there's less leakage. So this is becoming less of an issue specifically. But what this does is it sort of acts like a backing. Excuse me. Outside of that, though, there are the procedure itself done through a small incision underneath where you sit. It's called the perineum, and it gives access around the urethra to place this mesh sling essentially. This other one is more robust as far as how it works. This is a artificial urinary sphincter. This is for typically guys that there are some guys that have had surgery or radiation that just constantly dribble, not just with coughing and sneezing. They walk around and it just constantly comes out of them. They're going through 10 or 12 pads a day. It's also the guy that is probably the most affected by this because the volume of urination leakage is so much. And I see this typically in guys, not so much lately with the new techniques, what we're doing with robotic surgery, but it's also it's we're doing more pelvic floor therapy and help in that sense. But what artificial urinary sphincter is like a sort of a mini blood pressure cuff, and it goes around the urethra. This is a picture of it on the side here. Similar to the three-piece prosthetic you did for the erection thing, there's three parts to this as well. There's the cuff that goes around the urethra. There's a pump inside the scrotum next to your testicle, and there's a little small reservoir next to your bladder. And the way this one works is it's sort of the opposite. Instead of pumping to inflate something, you're pumping to deflate something. So there's a video I'll show you in a second. It basically shows you how this works, and I'll talk over the video as it goes. But every time you want to go to the bathroom, you have to pump this thing to open up the sphincter to allow the urine to flow out. And then it automatically closes on its own. So as you can see, you can't see it on the outside. It's all inside your body. So this guy wants to go to the bathroom, and the cuff itself is around the urethra. So when he squeezes that pump, it pulls the fluid out of the cuff and opens the urethra so the urine can come out. And then over the next couple of minutes, it slowly closes on its own. And then as you see, that small little inset that it's closed, and that holds the urine in. So typically when guys want to go to the bathroom, they stand over the toilet, they open this up, they pee, They wait a couple minutes, and then it closes on its own, and they're dry, and they zip up and go back about their day. So it's a nice way of holding all the urine back, no matter how much leakage you have. It should be pretty dry afterwards. As far as the procedure, there's actually two small incisions done for this one because that reservoir, that small bowl that's next to the bladder, has to be put in through a separate incision. But there's one incision underneath where you sit in the what's called the perineum, the area between the testicle, the scrotum, and the anus, and then one small incision in the groin, almost like a hernia surgery. So we put this device in while you're asleep again, and then you wake up, you go home with this thing open. So the cuff itself is not going to work right away. In about 6 weeks, I have you come back to the office and show you how to open it or close it, I should say, and that'll keep you dry after that. So the concept being is that it sort of acts like a squeezing around the urethra, but internally. So you don't have to see it, you just got to pump it to go pee. So as far as the success rate, very successful as far as continence and people using one or no pads a day. As you can see at 4-year mark, 85%, 96%, 6 years, and then 90% at 5 years. So this is a device that's really a game changer for patients. I've had people have had leakage for 10 years, had no idea this device existed. Some guys, the urologist doesn't do these, so they don't really talk about it, but I do. So when I get referrals from other urologists to me, they're like, I didn't know this existed at all. I'm like, yeah, well, this we can see what happens, get you dry. And the guys are leaking for 10 years, wearing 5 pads a day or 10 pads a day, and now they wear one just in case. And even those guys, they're so used to wearing a pad that they sometimes for the first year they're afraid to not wear a pad. And then after about a year of doing that, they're like, "Wow, I'm not even wetting at all. So let me just stop using this altogether." But it's really a life-changing thing because there's nothing nothing better than being wet and all of a sudden you're dry for the rest of your life. That's a real game changer. As far as insurance coverage, we look into this. Typically, often covered, but we always look into it ahead of time. So that's this is the some safety device. This is I think it's here you go. This is a guy, not my patient, but this is an example of the comments that I hear oftentimes. And they're like, "Oh my God, I'm dry. I can't believe it. I've been wetting for years, and now I have total control." And they're not bothered at all by having to pump a little thing to go pee. It's being dry all the time is a game changer for them. So that's the majority. This is a little video, which you don't need to hear that, but Bob's happy. Let's put it that way. So risk of this procedure, either one of them, anytime these things get infected, whether it's a sling or a sphincter, they have to be removed and replaced. So we do our best to keep these things as clean as possible, case-wise. And these devices also have a shelf life of use. There is, again, valves and things that can go and fluid loss and whatnot. So similar to the penile implant, about the 10 to 15-year shelf life on average of 12. But again, I have guys that have them longer. So, and if these things get infected or they stop working, you could replace it with a new one. It's not like it's a one and done thing. So that is, I think, the majority of it. Yeah, I think that's wrapped up. Yeah. So this is just the last slide. Just I want to thank Boston Scientific because they've pioneered a lot of these products out there, and they're the company I use primarily exclusively for these products as well. I don't get paid by them. I just I like their products. So if you have any questions, there are some phone number you can call to talk to a patient champion. I think someone had asked already about is there someone I can talk to that can say their experience with it, and there are people out there. So Preston can talk more about that, but there are we call them patient champions, guys that have had this done that want to talk about their experience. If anybody on here wants to talk to any specifically of my patients that I've done, you'd have to just call the office and I have a guy that I use for that's really happy and he's happy to talk to anybody. He's like my own best fan as far as this device and the success rate for him. So he's very happy to talk to anybody about it. Let's see if anything else I need to. I think the rest is just disclaimer stuff that
Yeah,
will
you can
just
just
circle.
kind of go through those. You don't have to really stop too.
Yeah, they're just, this is what the lawyers like us to,
Yeah, make
references and
sure that
whatnot.
we show all the references and give all
Yeah,
the.
I think that's all of it. That's the last slide, I believe. Yeah. So
Yes,
question.
and yeah. So I'm gonna go. Let me go ahead and stop the recording.